All right, let's move right on to Professor Kaneoka.
Okay.
Sacroiliac joint dysfunction in athletes and exercise therapy. And I think there'll be some tie, and I think it's just fascinating. I'm a huge fan of looking at how therapy and muscular contractions interact on the SI joint. And I think that's really a highlight of this whole webinar. So thanks. All right, Professor Kaneoka.
Yeah, thank you. Good morning, everyone. It's a very beautiful Sunday morning in Tokyo. Today, I will discuss sacroiliac joint disorders in athletes and their exercise therapy, especially the method that benefits of motor control exercises. I'm a spine surgeon and I used to perform many difficult surgeries at University Hospital. And I have also worked as a sports doctor, mainly supporting Japanese national swimming team for many years. Swimmers often suffer from low back pain. And in 2007, I moved to Waseda University, where I have been researching preventing for low back pain by activating deep trunk muscles. Applying the results of this research, we believe that we have actually been able to reduce the frequency of swimmers' low back pain through exercise intervention, and which has also led to improved competitive performance. I have outpatient clinics in several hospitals, and this data is from one of those hospitals. This graph shows the frequency of low back pain diagnosis. This data is not just for athletes, but sacroiliac joint patients make up 13% of the total. As you know, the sacroiliac joint is a synovial joint shaped like an ear, tightly stabilized by its surrounding ligamentous tissue, and has only slight mobility. This figure shows an MRI bone image. The posterior sacroiliac ligament can be seen posterior to the SIJ. This figure shows the ligamentous tissue surrounding SIJ. As you can see, multiple ligaments provide structural mechanical stability. SIJ can move slightly, and the nodding motion of the sacrum is called nutation and counter nutation. As shown in this figure, when squatting and bending forward, the nutation load is applied to the joint, and when extending the back, the counter nutation load is applied. And joint stability is supported by this mechanical stability and the functional stability of the intrinsic muscles of the pelvis, the transversus abdominis and pelvic floor muscles. These functions are also referred to as form closure and force closure. When I was working at the clinic at the National Sports Science Center, which is available only to top athletes in Japan, we conducted a survey of athletes with sacroiliac joint pain. The results showed that of the 100 athletes with SIJP, 70% were women, and the frequency by sport was highest in fencing, followed by wrestling and track and field. In fencing, the hip joint is moved to its maximum range of motion, and the trunk is moved back and forth, while the pelvis is fixed to the ground, which is thought to place a large load on the SIJ, especially posterior SI ligament. Here is a case study of a fencing athlete. She presented with SIJP since 7 months ago and felt pain during footing motion with her left leg. On MRI STIR image at the time of the first examination, high signal changes were observed within the sacrum anterior to the SIJ. And 8 months later, the pain had decreased and the high signal changes had disappeared, as shown in the right image. Therefore, we conducted a study to clarify the relationship between SIJP and MRI high signal changes. We performed MRI imaging of 24 athletes with SIJP and 28 athletes without pain, as shown in the figure. 2 radiologists blindly assessed for the presence of high signal changes. In the 28 athletes without SIJP, high signal changes were found in 8 athletes, or 28%. This frequency was comparable to previously reported data from healthy subjects. On the other hand, in the 24 cases with SIJP, 12 or 50% had high signal changes. Thus, more high signal changes were observed in players with SIJP. However, statistical tests showed no significant difference between SIJP and high signal changes. Therefore, we compared the frequency of high signal changes in 24 symptomatic patients divided into 13 who had symptoms for more than 1 month and 11 who had symptoms for less than 1 month. As a result, high signal changes were observed in 10 or 77% of the 13 patients who had been symptomatic for more than 1 month, which was significantly more frequent than in those who had been symptomatic for less than 1 month. Here is a case of a freestyle ski athlete. She had been repeatedly practicing rightward rotation as shown in the picture when the right SIJP appeared. MRI shows high signal changes within the anterior sacrum. We believe that during the landing of the rotational jump, a rotational force was applied to SIJ, and a compressive force was applied to the joint, resulting in bone edema. At the same time, a traction force must be also applied to the posterior sacroiliac ligament. In sports injuries, bone marrow edema has been reported to occur with traction forces to bone. As shown in this slide, high signal changes were observed in the MCL attachment area of a baseball player with an elbow injury. In addition, high signal changes within the pubic bone in athletes with growing pain and within the patella during jumper's knee have also been reported. These changes are thought to be caused by traction of ligaments and tendons of their attachment to the bone. As the traction forces to the tendons and ligaments act on the bone, inflammation within the bone marrow, increased vascularity, results in bone marrow edema, and continued loading results in bone formation at the attachment site. During this process, nerve tissue also grows in the area of attachment, causing pain, a condition known as enthesopathy. Spondyloarthritis is a well-known condition in which the sacroiliac joints are affected. It has recently been reported that the pathogenesis of spondyloarthritis is an inflammatory process that results from an excessive self-repair reaction to micro damage to the attachment of spinal ligaments caused by physical loading. As shown here, traction forces are applied to the anterior longitudinal ligament attachments of the vertebral body, resulting in inframedullary edema and eventually bone formation leading to osteophyte formation and eventual fusion, giving rise to the famous bamboo spine image. SIJ is reported to be almost 100% affected in spondyloarthritis. An article reporting MRI findings of the sacroiliac joints in patients with spondyloarthritis reported that the findings of inflammation at bone attachment and bone marrow edema could be seen, and these findings are similar to those in our athletes study. These findings suggest that when the pelvic ring becomes unstable, traction forces are exerted on the pelvic ligaments, and compression forces are exerted on the sacroiliac joint. We believe that the excessive physical loading in athletes and excessive reaction in spondyloarthritis causes increased blood flow in the bone marrow, resulting in bone marrow edema. And in spondyloarthritis, SIJ fused. At the same time, we speculate that traction force loading on the ligament attachment tissue causes neural tissue to increase, resulting in pain. In other words, pelvic instability causes traction forces on the posterior SI ligament. The mechanical load applied to the ligament attachment area causes microinjury of the ligament attachment area, resulting in enthesopathy and cause SIJP in the area of posterior SI ligament. Murakami et al. Reported that 70% of SIJP was alleviated by injection of lidocaine into the posterior SI ligament, supporting our hypothesis. Comparing the sacroiliac joint to the ankle joint, most of the ankle joint pain also originates from the ankle joint surrounding tissues, such as ligaments. In addition, exercise therapy for ankle joint disorders includes neuromuscular exercises of the periarticular muscles to achieve functional stability. Functional stability of SIJ is obtained through the activity of the intrinsic pelvic muscles, the transversus abdominis and pelvic floor muscles. Impaired functional stability is thought to increase the reliance on mechanical stability functions and increase the load on the sacroiliac periarticular ligaments. When the pelvic intrinsic muscle contracts before the extrinsic muscles, the pelvic ring becomes stable, as shown in the picture on the left. However, if the extrinsic muscles contract before the intrinsic muscles, the pelvic ring becomes unstable, causing SIJP. Thus, delayed activity of the intrinsic muscles and overactivity of the extrinsic muscles cause functional stability to be compromised. Therefore, neuromuscular exercises are required to improve this situation. There are three trunk lateral abdominal muscles as shown by Dr. Morito: the external oblique, the internal oblique, and transversus abdominis muscles. The transversus abdominis muscle, TRA, attaches to the transverse process of the lumbar spine via fascia, and its contraction provides functional stability of the lumbar spine. The left image is an echo image, and the right is a kinematic MRI image. Therefore, contraction of the TRA is thought to be effective in preventing low back pain, and draw-in abdominal pulling exercise that promotes contraction of TRA have become popular as a low back pain prevention exercise. There are various contraction styles of the trunk muscles: mild draw-in, in which only TRA is contracted; strong draw-in, in which the abdomen is strongly pulled in; and bracing, in which the trunk muscles are strongly contracting to form the trunk. I think these contraction modes should be used in different situations, like shifting gears in a bicycle. As Morito et al. Published last year, EMG analysis using wire electrodes has proven that when the draw-in is performed slowly over a period of 5 seconds, TRA is the first to become active. But only 1 second later, the oblique muscles, which are one of an extrinsic muscles, begins to active. Therefore, theoretically, pelvic ring stability can be maintained by performing the movement in the 1 second that TRA is contracting alone for SIJP patients. If the oblique muscles group contracts before TRA and the pelvic ring is unstable when the movement is performed, SIJP is likely to occur. Therefore, motor control is required to cause movement only when TRA is contracting, as shown in the echo image. Since lumbar spine stability is achieved when the oblique muscles are active, strong draw-in is also the recommended method for non-SIJP low back pain patients. Here is a representative case of how I evaluate low back pain. She is a 21-year-old female who has been experiencing low back pain since she threw a ball straight up 5 years ago. She came to my clinic after seeing many medical providers, but no SIJ diagnosis and no improvement. She had to quit her job as a cake baker, patissier, because she couldn't stand for a long period of time. Pain occurs near the right sacroiliac joint when bending forward, as shown in this video. And pain also occurs when extension of the lumbar spine and oblique backward extension. And I'll check the tenderness, and she had a tenderness around SIJ. She says it's painful. And also, low back pain is also elicited by the test of raising the lower limb in the prone position, so-called prone hip extension test. Next, SLR testing of the lower extremities also elicites low back pain. A SLR test positive. And in a passive manner, she doesn't feel pain. And the left side is not painful. She felt heaviness on her right leg. This is a repositioning test. But the right side couldn't be returned correctly. And the left side is correctly. And the muscle strength evaluation showed weakness in the left lower extremity. If there is instability in the pelvic ring and SIJP, SIJ is likely to be loaded when elevating the lower extremities, causing pain and a sense of difficulty. We have reported that the repositioning test assesses the loss of lower extremity positional sensation, but those with SIJP cannot be accurately repositioned. A block injection into the posterior SI ligament was performed to her to evaluate the patient's low back pain pathophysiology. The following are the findings immediately after the block injection. The patient's anterior bending pain, it better, and extension pain, it's improved. And the oblique backward extension pain improved. And the prone hip extension test became negative. She said it's getting better. And the SLR test getting negative. And it's a repositioning test after injection. It's improved. Based on these responses, her back pain was diagnosed as sacroiliac joint disorder. However, at a 2-week follow-up visit, her low back pain had recurred, and her forward bending pain and extension pain, it's returned. And also oblique back extension pain had returned. And this prone hip extension test was also positive. She said it's painful. However, ASLR test and repositioning test and muscle weakness had not returned. Therefore, I instructed her on how to contract TRA while watching the ultrasound image. First, we practiced contraction of the TRA while showing image. I explained about the abdominal muscles. And then practiced elevating the lower extremity immediately after contraction of TRA. It's not a good manner, but she's saying that her leg become lighter and no pain. Again, only a slight contraction of TRA. During 1 second, she's moving her leg. And during, just after instructed anticipatory contraction, I instructed her to contract TRA alone and then lift her leg, resulted in negative prone hip extension. She said no pain. And also reduced back pain during spine motion. Its range of motion, as shown in the slide, it's getting better. Left image shows before instruction, and her motion becomes wider. And she said it's a big difference. 2 weeks after teaching TRA anticipatory contraction, 6 weeks after first visit, spinal pain or movement has almost disappeared, and almost all findings are negative. Her back pain, which had been present for 5 years, was reduced by half in frequency and intensity. She said it works better than injections. She continued to do exercise at home, and after 3 months, she completed her treatment and returned to her normal life. And this case is a 21-year-old long-distance runner who developed SIJP after endoscopic appendicitis surgery. he felt discomfort in his groin and during walking. Tenderness was observed in the left SIJ. Repositioning test was positive on the left. We used ultrasound to teach him TRA anticipatory contraction, as shown in this video. This motion is mild drawing, only TRA contracted. And this is a strong drawing, contracting IO. And he instructed how to move TRA alone. As shown in the video, the repositioning test was positive before the interaction, and instructed to raise the leg just after TRA contraction begins. And he felt that his leg became lighter. And immediately after the practicing, the repositioning could be raised accurately, as shown in this video. For 26 SHAP patients, we taught anticipatory TRA contraction, and their NSR, ODI score, and RMD score improved within 3 months. Our clinical findings in this study show that despite the small amount of exercise intervention, the results are as good as previously reported conservative treatment methods. Treatment modalities for SIJP include medication, injections, and manual therapies, and so on. And for the regeneration to enthesopathy, PRP, prolotherapy, and shock waves are used. And for pelvic instability, it's treated with corset, or the last modality, surgical fixation. However, we believe that learning how to contract the transverse abdominis muscle prior to extrinsic muscles improve pelvic instability, and this method should be given priority over any other treatment methods. Finally, I present the case of 37-year-old wheelchair tennis player. He presented to my outpatient clinic because of his left groin pain at 2021. He had anterior bending pain, and which became more intense during wheelchair turning movement like this. I diagnosed SIJP because of improvement after block injection into the posterior sacroiliac ligament. And I taught him anticipatory TRA contraction, and his pain improved. And his SIJP has improved, and he was able to win the first place at the Tokyo Paralympic Games. However, after the Paralympic Games, while traveling around the world, SIJP came back. During that period, he was competing around the world without rest. As shown in this video, the pain was recurrent during 400 strokes. We believe that the rotational load on the pelvis was causing pain due to the load exceeding the functional stability provided by the transverse abdominis muscles. Therefore, we recommended a 3-week rest period in hopes that the tissues around the ligaments would repair. At the same time, we performed PRP therapy to further accelerate the healing of enthesopathy. As a result, he no longer had back pain during pelvic rotation, as shown in this video. And he was able to play in subsequent matches without pain and achieve good competitive results. Later, this athlete retired and was awarded the National Medal of Honor by the Prime Minister. We hope that the methods we have described will be applied around the world to help many SIJP patients return to their daily lives. Thank you very much for your attention.
Professor, that was absolutely outstanding, and I think I always think that if we can treat somebody without surgery, that's probably the best way to treat them. And I love seeing modalities like this. It really highlights a deficiency in my practice to highlight the TRA. And I was just asking the chat if there are some resources that we can give our therapy departments to really work on this. And I have a response in there, but we'll put some more references in there for people to look at this. That's fascinating. So thank you. We'll move. I think we're going to show a 1-minute video, Dr. Kurosawa. Is that right, from one of our sponsors? And then once that video is done, Dr. Hemakur is going to talk to about SI joint pain in adolescents and young athletes. So we'll start with the information first from Autobach and GE, our sponsors.